Deal.
But I thought I noticed with the working group, it's really a bit like these are long, selected and stuff.
Basically, but La Rochelle and yeah, so settled. So, yeah, there's always quite a lot of meetings.
Yeah.
It was better than here, it was warmer,
But not high bar.
but the last, the last 4 days. Is 24. And I think that's
It's very nice to be on loss at the end of this year, and then next year is going to be a lot later.
all right, good.
The earliest, one of the earliest possible things on the list. Yeah. And early Easter was good for me this year because I went away with my fiance to with his siblings who both have little children. We all went to the house together in Shropshire. Absolutely terrible. Yes, because Easter school days were after Easter, which meant we all piled in together after Easter. Whereas next year, because it's so late, I'm assuming like school holidays are later. You and I can't do free. So
We'll always be busy over Easter itself.
oh, absolutely, yeah, over Easter weekend and the week beforehand. Or it's usually busy.
Yeah.
Well, so. Yeah, and Jill went on leave because we did the after Easter Sunday, so she's sort of got to do Sunday, and then she kind of went she went over Easter, and I covered for about a week, and then I went to be my 20. So we got to Easter, but both sort of in the midst, and then I thought carrying on for a bit longer at the tour. Yeah.
So, hello everybody. I think we're just gone for, even though we've got the most weird seating arrangement now going, because we obviously haven't got available seats. So we can have a bit of a shuffle if anyone, but I suppose people might turn up. So we'll probably just best to push on. I think if that's all right with everybody, we've got some colleagues online, and Gary and Mark. Pen. Mark's waving. Very nice to see you. We won't wait for everybody to be wave or we'll never get on. So welcome to everybody. We were just saying we need some other people to help populate the gaps because it's looking a little strange.
There, you're next to Kate.
Oh, there.
We're basically interviewing Duck. Again.
Will be very nice. So welcome everybody. I'm just going to first do a couple of matters. So I'm going to take apologies, which Timmy, we've got 2 apologies.
Yes.
So we might have got not got apologies to some of the people that aren't here at the moment. We'll obviously note them as not attending. Are there any declarations of interest? I'm just going to say, okay, I'm just going to hand to Kate for a moment, who's going to kind of just talk about why I'm sat in this seat and what we're doing, and then we'll also sort of other appointments if you get them.
Yeah, of course. Yeah, thank you. So just on the matter of process, I think you will have all received, or hopefully you all received and seen an email from Alison Davis last week after the Governance Nominations Committee met and recommended that Alison be reappointed for a second term as chair. That appears in the paper later on in this programme, which we'll deal with when we get to. But Alison is not going to stand for a second term as chair because as she has said to governors and to the wider organisation, she has a caring commitment with her husband, which she needs to prioritise. So Alison is, was, I think, as she said in her own message to the governors, was really delighted to have been recommended for a second term and really sad to see the term opportunity down. So Heidi became as deputy chair, as vice chair on the board, became acting chair with immediate effect. And is going through some handover with Alison as well to make that as smooth as possible. And I know lots of people have expressed their very good wishes to Alison. Thanks to her for her great leadership on the Council of Governors as well, and that's okay on the board as well. So that means that the paper that we'll deal with a bit later on the agenda, fairly shorter than the agenda, which is the report from the Appointments Committee. There's a recommendation there that we will need to not approve because of Alison's wishes. It does mean that we will meet again to convene the NED Appointments Committee to decide the process then of appointing a chair on a substantive basis. But obviously Heidi is, I think Heidi comfortable to act as acting chair in the interim period.
And so I'll just say here while we're doing that. So everyone who knows I work for Supervisor, actually I had resigned from Supervisor last August. September, trying to escape. That's not humility. I'd actually was due to go at the end of March. We didn't appoint the first time round, but I've now appointed. But I am actually also now only operating a part of supervisor. So just to give that, I've got a hold of the ship, but it means I have got a bit of bandwidth rather than trying to run. I just also like personally just to thank Alison. I know she's not here, but just would like to say thanks to Alison for her friendship and support. Because I think she's been fantastic over the last 10 months, but she has been going through a very, very difficult personal time. And I've tried to support her as much as possible, but I think she's been a lovely lady to work with. So we wish her very much. Okay, so moving on, I think, to the minutes of the previous meeting. We've already commented that we've got a couple of amendments to make on the attendance. Christine wasn't at the meeting. Are there any comments on it? I have one question just on the badges and security badges for governors that was raised. Was that picked up? Because I can't see if anywhere picked up in actions that are taken forward. Is that carried forward in that to go with, or are we having to do that as an issue?
Isn't it?
Yeah, I don't, it was being debated. That's when I was there, scraping the door. And testify, I don't have one.
Okay.
But I thought we were going to have a review of, was there not going to be a review of who needed what?
Yes, so I just wondered whether that had happened, and I don't think it has by the sound of it. So Kelly, we'll just pick that up, won't we? And
Yeah, I'll talk to you about that.
And okay. How do we make the light TV?
Yeah, we're not very visible on the screen.
So the light on, have the light on, please?
Yes, thank you.
So, and just a note from the minutes that the eating and drinking programme that needs to move forward to July as well. So we just need to capture that in the minutes, which I've already sent to Tim. Cool. Just therefore moving to the action log. And I think we just needed to recall that in the action log, Jackie, she's correctly named, Janet, she's correctly named on the agenda, but she is actually Janet, she's Jackie. That's from today's meeting. Any other comments from the action log?
Yes, sorry, there is an action pocket about govern well. I think the action log didn't cover it, but it's not on hand. There is an action there.
We've got the well on the agenda. So yeah.
We'll cover it, we can cover it. Nothing else on the action log? No, super, okay. We'll move on to chairs. I'm not even remembering to look at the screen. We'll move on to the chair's update. I've only got a very short update this month. Alison, I'll be there this week. I just wanted to really comment on the fact of the informal governors meeting, which I didn't actually attend, but obviously there were some really good things picked up through that meeting. It looks like an excellent discussion. We talked about the governance role, talked about the meeting format, talked about the focus of information. And I think what that's leading to is that meeting we've just referenced, the government meeting to be planned for the 30th of the month. So I think that's really good news that that's travelling and got a journey in terms of the things that we want to work together on as a team. And the other point I just wanted to say, and it obviously is quite live this week, is that we'll need to do some amendments and changes to committee chairs. If myself sitting as acting chair, then we've got to make sure that we've got the appropriate people for other committees. And we're looking at that. I'm not going to rush to do it. I'd rather take a little bit of time and just make sure we've thought through how that work is best, but just to let the governments know that that's something that I will be working for, that we will I will talk about as well. So we do that to keep people updated. And I think that's all from me at this point. Shall I hand over to you?
Yes. Let me just update everybody, if I may, on the year-end performance. We finished delivering the emergency care target of 26%, and we were in the top quartile for the NHS, which is great news. It's great news on the one hand that we're in the top quartile. Unfortunately, it's a bit of a sad reflection of where the overall NHS performance has drifted to over the last couple of years. So delivered that. In addition, we delivered the 78-week target in all bar 37 cases, where a number of those were patient choice, but nevertheless, it was a very good outcome. And again, that put us in a very strong position nationally in terms of delivery of the targets. That's helpful. We'll have the financial year end shortly. A couple of other things that it's worth updating the governors on. We have had, just today actually, we've had the Sunday Times here because of the progress that we've made on technology and some of the work that we've been doing in Milton Keynes with the patients with type 2 diabetes and the study that we're running, whereby we work with individual patients and primary care to give patients an Apple Watch or equivalent and encourage them to walk. Individuals get paid to walk as part of this study, recognizing that it is cheaper for the economy as a whole to enable these individuals to become fitter and potentially reverse their type 2 diabetes than it is to just look after type 2 diabetes. So a good step on the path of focusing on health rather than illness. So we will no doubt be in the press at some point about that, which is probably a positive story for Milton Keynes. A less positive story that the Council of Governors may have read was that we were bottom in the NHS for the proportion of patients who were waiting more than 18 weeks for treatment. So that situation, we went into some detail and we helpfully had our response published. So this was effectively saying at the very highest level that patients in Milton Keynes were waiting longer than everywhere else. We got into a lot of detail with that. And what has happened since pre-pandemic times is that the number of urgent patients and the number of patients who are on the 2-week pathway for cancer have gone up by between 60 and 80%. And quite clearly, if you're referred into us as an urgent or a potential cancer, we see you very, very quickly. And what's been happening is that those patients have been bumping the routine patients that have been sent to us. So if you're referred into us as an urgent or a cancer, you're being seen very quickly within the timescales. If you are a routine patient, you're unfortunately having to wait a lot longer than a lot of organisations, but nevertheless, we are treating you within the dated 78 weeks. We will, at the next public board, bring back a more detailed response that will show that on average, the patients in Milton Keynes are waiting less time because quite clearly, we're seeing huge numbers of patients within a few weeks because they're urgent, and a handful of patients are having to wait significantly longer. So we will, and again, sort of put that in a bit more context. In 2023, 2024, we are one of the highest performers in the country for the volume of patients we are treating compared to the target we've been set. So it's not as though we're sitting back and not treating any patients. We're treating around about 30% more patients than we did pre-pandemic, which is sort of top 10 in the country. But unfortunately, we still, because of all these urgent and cancer patients, our routine patients are waiting a long time. So it's one of those things that's not the easiest to explain. Happy to take questions on that. Otherwise, I will pause.
I know it's probably speculation, but we all know how fast the population is growing in Milton Keynes. We all know how the demographic is shifting in terms of more older people compared to 20 years ago. Is it possible that that's having some effect in certain urgent referrals, or that's just speculation?
No, not at all. We know that we're getting roughly, I think it's something like 10 or 11 families a day move into Milton Keynes, and that trend will continue every day for roughly the next 10 years. So we know that those families, the broader population, are seeking care here, and the numbers of patients attending our emergency department are going up every year and so on. So we're definitely needing to increase because of the increased population. I think the other bit that we don't often sort of talk about is, particularly for our cancer services, the new cancer centre, and well, it's not new anymore. It opened in 2020. I've been there this morning and it just feels new still because it's such a beautiful building. The cancer centre, combined with the publicity around the radiotherapy centre, has effectively, along with obviously the brilliance of the teams involved in delivering services, has made the cancer centre of choice for Buckinghamshire, Milton Keynes and South Northamptonshire. So we are getting a lot more referrals from out of the Milton Keynes area because they want to come to us, which we have to manage.
You've got your hand up.
Thank you very much. Sorry I can't be with you. Joe, question on the capacity. I was the other Saturday morning, I went to the urgent or the treatment centre for a procedure, and coming from the car park, spotted something sitting in the 30-minute car park, the laminar flow operating theatre. What's the purpose of that? Was it a specialism, or is it particularly just to get the backlog down?
Thanks for that, Keith. The laminar flow theatre, the portable laminar flow theatre, although if you look at it, you wouldn't think it was portable, it is. It is there for two reasons. One is to give us some additional capacity, elective theatre capacity. And you, I hope, are aware that we were granted, I'm going to say, £3.5 million worth as part of the Salix government grants to improve our site and energy consumption here. And as part of that, we are doing some work with theatres and other parts of the organisation. And that theatre is replacing our theatres that are going to be out of action for, on a rolling basis. One theatre is going to be out of action for a number of weeks. And so that portable theatre replaces capacity that we would have lost. The reality is, sorry, I was going to say that the reality is that whilst we have that theatre on a 6-month contract, we have not made as many inroads into our elective waiting lists as we would like to have done, despite all the extra work we've been doing. And it may be that we think about how we increase theatre capacity in the medium term.
Thank you very much. Are you quite right? It certainly doesn't look portable when you have a look at all the things that are attached to it. But yeah, it wasn't there one day and it came in, and maybe next time I go around it will have gone. But thanks for the answer, Joe.
So we've had a recent related patient story, which is quite key to the delays in elective surgery. So this is somebody who's been on a long waiting list for routine surgery. They were scheduled, they're in the hospital waiting, they're on the table, an anaesthetist came in, said, I'm really sorry, I can't go ahead with the surgery because the patient had attended A&E a few weeks before and had been asked to go to their GP for a further test. So they'd attended, the GP had decided it wasn't clinically appropriate and refused. So the anaesthetist now saying that test needs to be done. The patient contacted us, frustrated that the wait had been long, but more frustrated because they also recognised what a waste of space that was, you know, that they'd held up that seat, that I think people are really aware of that. So are those things kind of put down to, you know, these are clinical judgments that people have to make, and there's an element of contingency, or what kind of feedback do we and reflections do we have on those about the kind of communication pathways, particularly with primary care, where a clinician's indicated something must happen, but then a different clinical decision is made and it's actually ended up in a cancelled surgery?
So we, if I start at the sort of highest level, the theatres are our most expensive part of the whole hospital to run. So you can imagine that, as you say, not only is it incredibly detrimental to a patient to not use an operating slot if it's needed, it's also a waste of money for the organisation. We currently run our theatres at around about 85%, and as a national benchmarking position, that's okay. It's not bad. The private sector run their theatres at a much higher capacity normally because they don't have emergencies bumping out electives. There's a bit of that. So at the very highest level, as an organisation, we're okay. Any theatre slot that is not used is a waste, and we do have a theatre users group that looks at all of the different cases to understand whether there's a thematic issue associated with it, whether it's communication with primary care, whether it's a particular procedure, whether there's illness in the community that's starting to impact whatever it might be. So on that basis, I think I can be relatively confident that the case will have been examined. I don't know the case personally myself. The one thing that we obviously do have to continue to enable is that clinical judgment right up until the point of the patient being anaesthetised or the operation being carried out. So in some respects, I take some comfort from the fact that the anaesthetist didn't do the operation in order that that particular clinical view was taken into account. But I get the frustration.
Yeah, I think the patient particularly wasn't frustrated. I think, you know, he felt that everything had been right. It was that point of failure between, you know, where Amy had said, please do this test, GP making a decision. And subsequently, actually, the hospital said, we won't do the test, we'll do the surgery. They've kind of refreshed it now. But that obviously took time and unfortunately ended up in that delayed way. Just thinking about the you know, impact on like you say, the beds.
So one of the things, just before we finish on that, and I never miss an opportunity to mention the NHS app. We are trialling nationally in 4 different organisations the ability for patients to complete their preoperative assessments virtually in order that we can pick up more of these snags before the actual treatment time itself. So we know that it will pick those up.
Really sure.
Yeah, so I think, did you say 78 weeks for the
Yes.
So I wonder if you can explain that, just exactly what it is. And the second question was, when I'm talking to various people, stuff is the gap between, say, a local GP and coming to the hospital, if you like, the mothership to the satellites, the complete communication gap when people sat in the hospital would be great. And the patient is then said, you do know about this information. No, we do not. And they've updated it there and then. It's kind of a shock. So
I'm going to mention the NHS app again, but we'll come on to that. So 78 weeks. It was 104 weeks last year. It's 78 weeks at the end of this year. that is the amount of time from going to see your GP who says, "Dear Joe, I understand that you have, looks like you need a hip replacement. I'm going to send you to see an orthopedic surgeon." That 78-week period takes into account the outpatient appointment and the procedure if you need one. So it's the entirety of, if you like, from referral to operation day. And if we take 60 weeks to see you in orthopedic outpatients, we only have a maximum of 18 weeks to have you get your operation done.
Okay.
So one of the things that we've been looking at this year is how do we try and pull forward the time that the consultant first sees you in outpatients, in order that you know what's happening, you know what's coming, and you're not waiting as long in order to have your sort of diagnosis. Because not everybody who goes to see the orthopedic surgeon requires an operation. So actually what we want to do is not make you wait 60 weeks for that initial, get you in as quickly as we can in order that we can discharge you back home if you don't need an operation, but tell you that you're going to have a hip replacement over the next few months. In terms of the NHS app, never miss an opportunity. One of the big frustrations from patients is that we know that they go to see their GP and the next thing is they hear several weeks or months later that they have an appointment. Actually, what's coming this year is the ability for the patient to track where they are in that whole process, which is really important.
So, yes, I agree. Quick question. When I took this out, what was a surprise to me? I thought automatically things from the GP go to the hospital, but I had to give a second permission to the GP to authorise the transfer of information, which I assumed was there.
Absolutely. Absolutely. You have no idea how precious your information is.
Okay.
Map authorizations, those steps are written in tablets of stone.
So can I ask a third question? Can I ask a third one? So when you have family hereditary information, like father, mother, etc. So if you take me, for example, I find out there is history that I didn't know that is relevant and changes the way you're treated. Is there anything NHS UK wide where biological information, you understand what I'm saying?
I do, I know exactly what
do they have a right to know?
No.
Because it will make a huge difference to their treatment diagnosis.
No, in one word. At the moment, there's no right to know on that familial connectivity with disease. That's
It's a good question, though.
absolutely, yeah. We'll get there. We'll get there. Because interestingly, a lot of the public expect us to know, and we don't because we can't.
Yeah, I'd just like to say in respect to the NHS app, for some reason, sometimes it just decides it doesn't want to know you again. And also this week, because two practices have combined over the bank holiday, Kingfisher and Newport Pagnell, the NHS app has not been working for certainly the Kingfisher patients. So, you know, glitches in primary care can mean that unfortunately the app is inaccessible.
If
And I ask
only,
all people to write to June.
if only I controlled primary
If
care.
only you did, yes. If only somebody did.
Anyone.
But yeah, it's unfortunately, it's because it's so complex, it's subject to not working at times.
I think it'll take baby steps and then suddenly it will start to work fully and fully, won't it? That's often the app development and there'll more tools for people to use. She says hopefully, he's not being so hopeful, but I think
No, you're absolutely. I don't want to bore people, so therefore I will for a moment. A year ago, 14 million logins a month. Last month, 31.5 million logins. So when you think of the volume of people that are getting, a year ago, 10% of the population had access to their medical records through the NHS app. As of today, 85% of the population. That still means that there are 15% of the population who don't. and that's absolutely linked into primary care. So it is absolutely incremental and developmental, but it's staggering how many people, how many organisations.
I was, I'm not on the app because I'm not very good at downloading things, but that's another story. But I was concerned that I heard, and it might not be right, that all your information goes on there. And I was just wondering about people finding out bad news only on the app.
Yeah.
Is there something in place that means that they get face to face the bad news?
So this was an issue with, what's nice about Milton Keynes is that we do these things, and then about 5 years later, the NHS Act does. So, well, we tackled this problem here many years ago, and when you come to Milton Keynes, there is a test done in Milton Keynes. There are inbuilt delays before things get published. So we've taken the decision, the clinical body in the hospital has taken the decision that if you have a blood test done here, it can be published immediately, even if that blood test is out of range, because it won't give you a diagnosis. If you have an MRI or a CT scan here, then there is an inbuilt, and I'm going to say 2-week delay, whereby the clinician, if there is an adverse result or report from the radiologist, there is a 2-week window for the clinician to phone the patient to say, the X-ray shows a shadow on the lung, we want to see you, come in and have that conversation. Nationally, there is a problem with one of the GP IT suppliers who publishes everything immediately. So there are patients in the country who will be getting information, clinical information about their diagnosis that may suggest cancer without it having been through that delay period. Point number one. Point number two, and then I'll shut up. Every hospital that I've ever worked in, including this one, every year has serious incidents where patients get lost in the whole process and turn up in the ED several weeks or months later with stage 4 inoperable cancer because they got lost in the system. The nice thing about the NHS Act is that those patients will have the information that they have got a problem diagnosis. And if you read a report on there that you have a shadow in the lung, you're going to be on the phone and you're going to be saying, I want to be seen. So there are pros and cons for the publication of this data. But everybody has the ability to receive information on paper.
Really good point. People do plenty of airspace coming here.
Yeah.
Are you finished? There was nothing else.
Nothing else. Nothing else.
Thank you. Excuse me. So in terms of my updates, so since the last COG, we've had quite a busy few months and weeks. And I will summarise it because I'm obviously aware of the time. Between then and now, we've had the non-exec director shortlisting interviews, and there myself and colleagues met some very interesting candidates, which led to the recommendation that you have within the report. You will see that, and also mentioned by Heidi, we had the informal governance meeting where a lot of things were discussed, and we have a way forward, which is really, really exciting and actually paves a way forward for us governors, the non-execs and the execs to work better for the benefit of the hospital and the people that we represent. Through February and March, I've personally been involved in discussions with Heidi and Kate about how we better review and prepare for a chair's appraisal, chair renewing their terms and things like that, because that wasn't in place. And hopefully that will, as we go forward and the new chair comes in, it won't be an issue in the future. Furthermore,
We've also had the terms of reference for the next appointment committee panel, something else. That William Butler helpfully put together for all of us. It's been circulated, we've all commented, and the appointments panel had a discussion about that. We raised a few comments, which again are in the pack for you to consider and have discussed later. And in terms of this month, obviously we've heard the news about Alison, totally understandable, and obviously you'll leave a gap that we have to ensure that we fill that space appropriately with the right person when that comes. But in the meantime, we're going to have to work together with Heidi to ensure that everything is really smooth, so that of all the things that are on Alison's plate, this is, so that's my update.
I just want a technical point. The appointments committee terms of reference. The people should have invented it that way, well, something that's a it's a must. Technical point is it highlights the fact that the elections, once we start the process, should normally happen in April. And it's the trust secretariat responsible for doing that. And obviously, we may not be in a situation where it can happen in April, but clearly, because we need to, in a sense, get that rolling, we need to have some plan in the near future. So I think it may not happen before the end of April because we're only just really now.
Yes.
That's why I got the word.
Yes, okay. We need to pick that up.
Well, and before we continue, I should mention, I had a meeting with an introductory meeting. We've got to understand her background and what she's bringing to the hospital and how we can work together. I'm quite happy and excited that this is the start of a very good relationship amongst the secretariat and the governments. So that's really good. So Kate, I think it's open to yourself.
Thank you. Yes, a couple of papers here. One we've sort of talked briefly around already, which is an assurance report from the non-exec directors appointments committee. There are a number of different things that the committee discussed when it met. One, as William just touched on, is the revised and refreshed appointment committee terms of reference. So in January, COG, we had quite a long discussion around making sure that was fit for purpose. Everything you need to do involve the right people, it met with the right frequency and etc. So lots of work's gone into revising those terms of reference and making sure that we are able to manage future appointments very proactively against terms of reference that are every is appropriate. So that is one of the items. Then the item around the formal approval of Sarah Whiteman as non-exec director. It's not come on to the sort of proposals for approval in a second. Chair's appraisal is also discussed at that committee. That is part of the role of the committees to discuss the appraisal and performance of the COG overall, and then reappointment of the chair. So Kemi has broken down the decision and comments very clearly in this paper, so it's very easy to follow. And there were three recommendations. Firstly, which we could recommend to the council to approve. That was the approval of the appointment committee's terms of preference. Unless anybody else has any further comments to make on those. The formal appointment of Sarah Whiteman as non-executive director for the trust board. Most of that people here. And then the third was obviously not one we're going to recommend to the council now for reasons that we discussed at the start of this meeting, but I would ask that we, the council, approved to do so, would have formally approve Heidi's role as acting chair this interim period.
Can I ask a question? So we will note that in the previous meeting that the committee obviously recommended.
Absolutely. That's why we wanted to bring this paper that said clearly that the committee recommended us for the second term, but obviously in between period absence. Has not taken that term on. So we'll just make sure that's clear in the minutes as well.
That's good that we extended your term.
Yeah.
I think we're move on to the next item.
So again, at the January council, we talked about development of the council and about getting the programme that we've had previously, Govern Well, who are sort of, I suppose, experts in governor support and NED support development and training around roles and responsibilities and effective working assurance models and etc. So we have circulated a date for a session with Govern Well, and I think the majority availability for that date, which I think is in May, isn't it, at the end of May? And this is a proposed agenda, so that Govern Well and Kemi put this together based on what we talked about here at Governance before, around what we think is going to be most useful. So I think Government's being asked to discuss the plans for the upcoming session and agree the agenda based on what we think we need. Obviously it can be somewhat flexible on the day, but just this is what we thought was a reasonable agenda, going through sort of statutory roles of governors, the difference between the respective roles. I think the big issue I think that we've discussed quite a bit is how do we do accountability and challenge and assurance well? What does that mean? What do we follow, and how will we gain assurance? And then a bit around sort of team building, trust, a bit around effective working and the sort of broader roles of governors around membership and engagement. It looks to me like a good agenda and quite a lot to get stuck into put one day. Yeah, things.
I just have one comment about, I think one of the things that we've been struggling with a little bit, and I'm not sure we've quite bottomed it out, is about the framework in which we operate, and in terms of when we have this meeting, at what stage have we got an opportunity to ask questions? When do we give our feedback? So I think that framework isn't quite sorted out yet. And I wonder whether there might be a section somewhere in this day that perhaps they could come back and say, well, this is where it worked. We've worked with other trusts and it works really well in this way. And we can discuss with non-execs in the room, say, well, how would that be for us? Because I think it's a bit like herding cats at the moment. It feels like we can't quite pin something down and say, right, that's what we're doing. So I just wonder whether that might be helpful, or whether anyone else agrees with me about that.
I recently attended the Govern Well training. I volunteered to do it, but I think I was the only attendee from Sussex there. The agenda looked very similar to the layout of the online training. It was a really useful overview. I think I did it years ago when I first joined the government. But I do agree. I think there's some extra element about having the opportunity to work as a board on any kind of specific issues, and if that could be embedded into the day, because I think it was a really good overview, and I think it really helped to break it down. Just some element of being able to potentially workshop how that would look at our level.
Yeah, okay.
I think the thing that might be about how really,
Yeah.
in terms of
challenging discussions then. That's
Yeah.
what the
Yeah.
point rather than it is the process. So
I think a good next piece of work we talked about previously was around the timing and the flow when things happen. So just from a very functional perspective.
Yeah.
About we have to do that looking at board committees and the overall sort of work programme for everybody throughout the year.
I think that would be helpful, because if we look at this agenda, it's got a lot of stuff in it. And then you look at this and think, okay, when is our opportunity actually to have the meeting of the next and to ask questions? We're still not clear, I think, when we actually.
Right, which one was what's the practical?
Yeah.
Sure, that is that actually.
Exactly. I just wanted to sort of make it real. If you look at this agenda, you still think, well, where is our opportunity to ask those questions? Anyway,
so then as we develop agendas for meetings going forward, think about that as well, not in terms of having enough. It's not just talking about the anthem.
You missed that treat.
Yeah, first of all, totally agree with you. Obviously, it's face to face, and I think is the better option. But I'm out of the country, so I have asked that we have an online link.
Sorry. To that point, will it be recorded? Because I'm also have a conflict that.
So we can.
Thank you very much.
Just wanted to say I can agree with what's been said as well, but also as a very new governor, this looks really, really helpful, and I just want to say that, so thank you.
Okay, and that's for you.
So we're happy with this structure. We'll try and add in the sort of practical element of planning, maybe either to the end of the day, or if we can't do it on that day, maybe we'll convene a very quick follow-on from this day, either virtually or in person, do that sort of practical element. So, yeah. I
think if we can possibly get it into that day, I think that would be really, I think if we leave it, we won't have the same people in the room, and I think that would be disjointed and more difficult.
I think if you have opportunity to speak to the tutors on it, I think that it's easy to put that into the how we get assurance holding to account bit. Those bullet points, I think they should encompass that, but they might not know that.
Yeah, absolutely. Yeah.
I think the brief and not spend too much time asking some people read. We need to spend time on how we actually play that out.
Well, and I think a lot of the governments will have been on the training that the vaccine is on. I certainly was some months ago, so it looks the same.
Yeah, I think it is really similar. And the case study I particularly found helpful. And I think, yeah, it is about framework, how we get that flow of information, like you say, so that we can put this to account and we can understand how that trail of information goes. We have opportunity to discuss papers beforehand. We can analyse it, the skills, and we can analyse them in ways so that we can assess their quality. The case study in particular was very helpful in terms of looking at a paper you've not seen before and then being able to kind of ask raise clarifying questions and questions around assurance are quite good.
So are you envisaging a 10-minute workshop, a 1 hour? Genuinely, what sort of?
To be honest, I think you've started a lot of the work. I think William's feedback in some of the email trails that we've had, I think a lot of that is really coming together anyway. So I think a lot of that groundwork around the discussion seems to be quite rich in the email discussion. So
It's in the diary for 6 hours.
I'm trying to get in a workshop. All right, using the 10-minute workshop or a 1 hour workshop. Is it makes a difference to what you
Leave it to that, that's their job, isn't it? Yeah. We'll ask them about it.
Very good. Any other comments on the government plan? I understand what we're doing here. That's good. And I think it's you again.
Excuse me. This nice. You can tell the things that Kemi's put together. They look beautiful in my one that I did. It doesn't. So this is governors who've been on the council for across a year. Will recognise what these are. New governors. We are every year as part of our annual reporting cycle, we put together something called a quality account. And that both looks back at a number of quality priorities and a number of statutory indicators for the year before, the financial year before, and then looks ahead at what we want to achieve in the next financial year. For anyone who's read a quality account, and you receive it as governors, so you would have seen it. It's very prescribed format. It's not the easiest to read document, and it's been the same way for a number of years. As part of what we're required to do in that annual account, we have to pick 3 quality priorities that we want to focus our efforts on throughout the financial year. And those increasingly we've tried to align with work that we're doing in the organisation that's important to us around our board quality improvement programme or areas of important focus for the organisation, so that we've got consistency across work programmes and these priorities aren't sort of sitting out alone. So they replicate across our priorities. So our priorities last year were to reduce deep tissue injuries and pressure ulcers, to improve how we manage sepsis in the organisation, and to improve reporting rates of low harm incidents. And we've actually done really well on each of those areas. our pressure ulcers have reduced very considerably across the organisation. We've got a very significant quality improvement programme ongoing in sepsis management, particularly in the emergency department, but also across the organisation. And we've seen some very significant upward trends in a positive way in our reporting rates. So we've done well against our previous priorities, and you'll see the detailed report when that comes back to the Council of Governors in the next month. But our job today is to select the quality priorities that we want to focus on for next year, and there can only be three. We've got to pick from three from the list of 6. We had a discussion about this at the Quality and Risk Committee in March around what we thought those 6 could be. What we're proposing to you would be, with any of these 6 would be positive things to focus on. One is to continue our focus on sepsis. In previous years, we have carried over priorities from one year to the next, particularly if they're large programmes of work. One of those previously was pressure ulcers. Actually, we've carried it over years in order to keep our focus on it. But there's some changes around sepsis and the deteriorating patients over the next year that are important. One is Martha's Raw. You might have read the story of a young teenage girl who sadly died as a result of pancreatic injury and sepsis. There's a rule that's coming in around parents' right to a second opinion, which links to how to manage deteriorating patients. And also because we've got this sustained programme of work throughout the organisation and focusing on sepsis and deteriorating patients. The next one, number 2, improving complaint response time. So improving patient experience by looking in great depth at our complaints process, how we might improve that, how we might make it leaner and shorter, and be able to answer the patient's complaints in a more timely way. And we're seeing the volume and complexity of our complaints increase actually quite significantly, particularly on complexity. So that's an area that we want to focus on internally anyway, and so forward as a potential priority. A reduction in the number of complaints we get that cite poor communication as one of the main contributing factors. So this comes up in our patient surveys all the time, and it's one of the most prevalent factors in complaints. There's been a communication breakdown, either in the way we've communicated organisationally or in the way the patients have developed communication with once they're in the organisation. Quite a specific one, improving prescribing safety, particularly for an antibiotic called gentamicin. And that's because we've had a number of incidents where gentamicin prescribing has caused harm or has had the potential to cause harm in patients. We've got a prescribing safety group that's been focusing on that piece of work, and that's an important piece of work. It's an often prescribed antibiotic for movement to ensure it's prescribed safely. Reduction in the number of falls, and that's an area of focus that will continue for us anyway, regardless of whether it's set here as a priority or not. It's a big quality improvement programme. And finally, the effective implementation of the patient safety incident response framework. That's our new way of investigating patient safety incidents, part of the new national patient safety framework. And something actually we're mandated to do. So again, all of these things are things that will happen just because we don't select them here, doesn't mean that nothing will happen with them. It's just what we want to particularly focus on in our published quality accounts. So I don't quite know how to do this in the most effective way possible. But
I don't think any questions, just a minute or so, and then each one.
I found this quite difficult because it said the following proposed, but not by whom. So I didn't know who would actually propose this. Is this the non-execs?
It's a quality committee. Yeah.
Okay, and that comprises
non-execs and execs.
So this is a recommendation that of these 6. And I don't think we haven't really, you've given a bit more detail about these 6, but not really about why you've chosen those ones as opposed to others. And I think it seems to me, if I was being asked to choose, I'd say I don't have the information possibly to make that choice, because I don't know how many patients that, I don't have data on, well, if we did reducing number of falls, what quantity is that? I don't have any basis on which to say, well, those 3 would be better than other 3, because I'm not close to it. I mean, there may be people on the directors, on the governors who are much closer and can make a better decision, but I certainly don't feel like it'd be literally like me putting a pen in and go, well, let's have those 3. I don't have nothing, I haven't got anything meaty to tell me to guide me here.
as I've just been on the training, I think, yeah, I felt similar. I think this was a really good example of where we've not been given enough statistical information or data or rationale around why. I think this is different because we've been given a range of choice. I think in previous years, we've been just recommended the 3 that have perhaps been decided. I did try and do some digging and find the minutes from the committee, but they weren't available. But I did go to the board papers, the last report, and saw a few things that kind of linked to it. And my questions were, which Kate has just expanded on a little bit, was around what's the purpose of putting them as a priority in the quality, specifically around those quality priorities. So you mentioned the sepsis has a specific QI group around it already, and the gentamicin, I saw that in the incident report and some of the incidents that have led to that investigation, and the specific incident response has been put on eCare to kind of prompt those things. And my first thought was perhaps focusing on the effective implementation of the incident response framework would hopefully kind of work on those 2 things. Does that make sense? So you've got those programs running already.
These are all priorities for us organisationally. So in previous years, I've been, I think, responding to sort of to feedback from governors at the time that they didn't want to recommended list because they wanted to be able to make a genuine choice rather than being told what to choose. So, I mean, maybe some too far the other way. So maybe some too far the other way in not doing that. And so these are all priority areas for us based on the information that based on organisational data. So reducing the number of things like safety and prescribing, sepsis management are all key safety concerns and issues for us in the organisation. So that's why we want to focus on them. So really, these are the quality account itself is a document we want to align with organisational priorities. So in many regards, if we picked any of the 3 of these 6, it would be positive. It would align with what we're doing organisationally. It's what we want to say publicly. These are, in our quality account, these are things that we can measure well and that we can report on well. So things that are easy to measure would be the number of falls, reducing the number of falls, easy to measure with a smart metric. And we know what the number is. We can measure very clearly against the number of falls. Effective implementation of PISA, it's really, really important, but much harder to measure. So when we get to next year's quality account, we'll have a harder job in trying to work out how effective we've been in implementing it. So if I wanted to choose between 5 and 6, I'd choose 5 because it's easy to measure and we can clearly see progress. And then from an accountability perspective, that makes your job easier as accountable governors by saying, well, actually, you didn't do very well on that, or you did.
When do they need to be chosen by?
So we need to choose them today because we are running up against our deadlines for consulting because our board meeting.
When you respond to the question about what we can share, that might help give some more bit because there's many quality priorities, aren't there?
Well,
so this is presented as 6. Obviously, I wasn't aware of the last year. We confirmed the 3, but we don't get the way around. I suppose we're going to have to think if we need to make a decision today about how we're going to.
But we can do it outside. We can do it outside the meeting, and people can, vote with a preference, and we can do it that way. Or we can, and I can put some more narrative against each of these around how they'll be measured, and why they're important, and what metrics they might link to. If that makes it more straightforward.
Yeah, I think Rachel makes a very valid point about the need for information in order to make a decision. Having said that, the way the system works, clearly the decision has been, and I think for me one of the most important things you said is all these things are going to be done anyway.
Yeah.
So in a sense, it feels like a bit of a false kind of thing. It's a kind of almost PR.
Yes.
So you might say, well, therefore, what does it matter which we choose? Having said that, I think if we're looking at a basis on which to choose, I would prefer to focus on one, the key ones which there's a lot of behind. We have to make sure we follow through. So the sepsis one and the effective implementation, even though that's difficult to manage in the culture account, we should be choosing things because they're easier to collect. What we need to look at is how do we find a way of measuring those messy outcomes. So, I'll be saying very much let's focus on the ones where there's some progress, where implementation is important. And the other one I would highlight, I'm sure all would, is bloody communication.
Yeah, I agree.
Don't get things together and say, because they're two sides of the same thing. Sorry. Yeah, thank you.
The three I'd highlighted were 1, 3, 5, and I did the falls. Because I think we probably can come to a decision. I think falls, like you say, it's a Milton Keynes wide issue, not just the trust, but it's an issue throughout. I think it was obvious from when Healthwatch Milton Keynes came to some work around the improving system flow. It was really obvious that the lack of awareness amongst patients about their falls risk and it's there the things. I think that is really important, and it's and like you say, it's measurable. And we have to remember the quality account is a publicly facing document. It's there for patients and residents to read, and so they need to be subject matters that resonate with them and they can see that.
And I think probably William's one of them 6. He said that might be next year, but I think it's already.
Yeah, and that's something you've got to do. So you're going to have the focus, but members of the public might not say. I think in terms of reducing the complaints of communication, again, hopefully that would in turn improve the complaint response times. That is about capacity, but capacity, if it's all tied, a lot of it is statistically tied up in communications, that can help. And again, I agree with William on the thing around sepsis. It has a lot of public awareness at the moment. It does need that focus. Thank you.
Mine is really governance point actually. I think having done a lot of training, so I've done quite a few of the courses now. What becomes really clear is our job as governors is to hold the non-execs to account, not to be making decisions, not to be. So actually, my own understanding of the governance thing is that actually our job would be to receive a recommendation from that committee and then to be able to ask various questions of that recommendation. So actually, I think the previous system, if I read the rules and look at governance correctly, if I've understood it correctly, we would normally be expecting a recommendation from that committee, and we should then have a forum say, can we just understand how you came to that decision? Because that's our job, is to check that those decisions. So that's just something to consider, because I'm not sure that anyway. That's I'm going to shut up. That's my understanding of the governance sort of process from the training.
Yeah, I'll be very quick, as I was conversations developed since I was going to speak, but I agree. Points about sepsis, and if we're halfway through, it seems to be part of that, so we should finish it, get it done. And I would say the communication is super important, and I'm reasonably ambivalent / not strictly educated enough to be able to make a third choice. So I do, but I also agree with your points.
I know nothing about the relative kind of importance of any of these, particularly within sort of a medical terms within a hospital. But I think that what I could potentially say as a complete layperson medically is that numbers 4 and 6 would be for me the hardest to communicate more broadly to people in constituency, because they require a certain level of particular medical knowledge to sort of understand or kind of understand the processes with. And so I would think, for me personally, I don't know if anyone would agree with this, but 1, 2, 3, and 5 are the ones I find more easy to communicate broadly to kind of constituents and would have the most kind of weight because they are most understandable.
I personally would go for 1, 3, and 5, but I want to ask Kate a question. What would you go? 1, 3, and 5.
There you go. We're heading towards consensus.
Yeah.
I can't remember 1, 3, and 5. Which one's communication? That's a waste of time, isn't it? I'll tell you why it's a waste of time. Because 87% of medical legal cases, communication is issue. We're always going to have communication mentioned in almost every complaint. So it's unmeasurable. You're wasting your time with it. I'm not saying it's not a great thing to do, but it's not going to be effective. Whereas things which are measurable, as Kate has said, is number one is sepsis rate. Secondly, you've got falls, easy to measure. You get gentamicin areas as well. But if you want to help a lot of the population, then get the complaints process streamlined and stop the aggro we get and make people happy that we're being listened to. So I would pull that in. I can't remember which numbers which I was doing.
Yes.
That would be just looking at it from that point of view. And at the end of the day, shuffle.
So I think 1, 3 and 5 is sounding like it's got the majority of view on it, unless anyone else wants to add anything on the line. But if we were happy to make ourselves, no.
I would say communication, and there's a Bedford has just implemented a really good tracker tool that's emails out to relatives for cognitively impaired benefits, just a brief update of what's happening. That we were just meeting on, and it was a great communication tool just to get that little bit of update to relatives. It seems to have got bigger fruits. It's so that it's a tracker. I called it a tracker program. Yeah, I called it a tracker. Which one was because they weren't really, they were just relatives with permission, obviously. You know, basic information, which is really good.
I think we're agreeing 1, 3 and 5.
So perhaps for next year, we have a quality priority forum of governors where we meet to discuss the quality priorities in more detail, and a sort of presentation for perhaps in the early parts of April. And we schedule that in, so we try to get this process sort of right as far as we can take those.
Kate, am I right in saying that PSURF will be more developed than then?
Oh, yeah, launches in May. Yeah,
that would be obviously target.
Yeah. But all of these things will continue to. All of these things will happen. These are all going to be focus areas for us. It's just simply about what we report in the quality account as our measurable. And the quality account itself, as you know, that's the stakeholder who receives it for comment, is a deeply impenetrable document of the message types.
Before we move to wrap up, these 6 are you okay with us discussing this with people that we come across? Because I see lots in social media complaining about lack of communication and stuff like that, but people don't seem to understand what our priorities are. They're there, and that we are looking into them, and we're not ignoring them. If they were aware of the 6 priorities, they can go, okay, all right, it's not feasible right now, but it's been thought about.
Now, I'm going to move the agenda around very slightly because Hader, who's online, needs to do his piece and then step away. So Hader's going to do the charity fundability update. So I'm just going to go to you, Hader, and then hopefully that. Please.
Heidi, thank you. Can everyone hear me all right?
Yes.
Brilliant. Kemi, will you share the slides? Fabulous. Thank you, Timmy. So hello from a wet and rainy Dubai. I'm away at the moment. Some of you might have heard about the flooding, which is where I've got to step away and try and get some food from somewhere in a little while. Just a quick note, it's been a bit hard to hear you, so forgive me if I repeat anything or if I can't hear one of your questions. I might just need it repeated. Next slide, please, Timmy. So I've just got a few slides to help give you a quick overview of the charity and what we're up to. Our last CFC meeting was on the 25th of January. Some of my figures are a little dated, but as of the end of December, charitable funds reported an income of £289,000 and an incurred expenditure of just over £200,000. As a quick reminder, we spend our money on staff welfare, patients' welfare and amenities, and obviously running costs. Early indications for the year ahead. Sorry, just stay on that last slide, please. Early indications for the year ahead, end of March, are that we've raised £125,000 more than last year. However, please don't share that. This is yet to be confirmed. And I think the only other thing I'd highlight, and this is something Vanessa, head of charity, asked me to speak to, was most of the current funds we have are restricted to appeals, which I'll come on to in a minute, and so fairly limited on what we can spend against. And so really our focus going forward is going to be to try and raise unrestricted donations so that we can spend it against the greatest need as it arises. Next slide, please, Timmy. Okay, so what are we spending our money on? For a few years now, we've been spending it on a role called the Meaningful Activities Facilitator, which has been very successful, and we're building a business case around to hand it over to the hospital as a substantive post. I'm sure at some point you'll have a presentation around the MAF role, so I won't spend too long on it, but it's been really good at looking holistically at patient needs within the hospital, trying to distract older patients from the day-to-day realities of either their care or just being away from their loved ones. And it's had some really, really great feedback. We also spend some of the funds we raise on equipment to make things more comfortable for our patients, especially within the cancer center. And we've also spent money on incubators, and there's a picture of them in a minute, that have been very successful. And then the last few things, cardiology and family rooms in ICU, as well as children's entertainers. And Timmy, if you can move to the next slide, there's some pictures. The children's entertainers on the left there. The MAF role is in the middle at the top. VR headsets on the right. So we try and look at innovative technologies as well. Baby Leo incubators on the bottom right, and some of the screens. And to be completely honest, I have no idea what the picture on the bottom left is, but it looks like a fundraising activity. And I did try and raise funds for in the Brighton, London to Brighton bike ride, but it was a lovely sunny day. So again, I'm really not sure what that is. But I hope that gives you an idea of some of the activities that we spend our raise funds on. Next slide, please, Timmy. So priorities currently, we're raising funds for the radiotherapy center and focusing on well-being. There are also some family rooms that we're raising funds for in the cancer center. And as I mentioned a minute ago, unrestricted funds urgently needed so that we can target the greatest needs. And as a quick reminder, staff and others can put in applications for funds. So some of these ideas come directly from our staff in target areas that are of great need, and then are scored by the charity and the staff, and then commissioned on the basis of that. Next slide, please. Thank you. So I think this is the last slide. How can you help? Please do direct people towards the charity. There is a website that is listed there. You can also contact the fundraising team directly through the dedicated email address. And as it says, Vanessa and Jody would love to hear from you. And I think the other things I'd highlight before I turn it over to any questions, if there are, is some of the other areas that we've been investing in our on-site presence. There's an app called My Thank You that we've been rolling out to try and give people an avenue really to say thank you to staff, and if they wish to donate as well. We've done a lot of networking with local businesses to raise awareness, and signed up to new corporates, MHA McIntyre and Pertemps Medical. Both will support with sponsorship, but are also pitching Charity of the Year status, and that will be confirmed soon. We've been actively building towards the gala ball, which if you'd like to attend, that would be amazing. And again, please get in touch with the charity. And then we've also, as you may have noticed, invested in our brand, which has changed. So you'll see the new logo there on the bottom right, and promotion of other tools that will help us with the fundraising we need to do going forward. And I think with that, I will finish the update and welcome any questions. Oh, and the Charity Gala Ball is taking place on the 18th of May. Tickets are £100 per person, and you can also purchase tables. But yeah, any questions?
Thanks, Hader. I just noticed that you, in the I think I heard from the accounts you were talking about, that £89,000 wasn't actually spent last year. I just wonder why that was. I mean, your excess of income over expenditure was 89 grand.
I don't think I mentioned that, to be honest.
Just wrote income of 289 and expenditure of 200.
That was a figure that I received in January. It wasn't a year-end figure, so it's not the final figure. It's just the update that we had in the January CFC, and based on figures as of December. Year-end has been indicated as a profit, I think I said, but I haven't received final figures, and the next CFC meeting is going to be in a few weeks.
Yeah, just to highlight a couple of things at FMA, I think the medical facilities post, I think it's important to stress that the charity is being funding now as a pilot. And I think that's a very kind of standard process for these kind of situations. That's try something out, you test it out, and then the trust picks it up. So we're now at the stage where there's just, I think that's important, that's an important model to kind of reinforce that we're not just paying for it forever. I think that's the first one.
That's right. So we've in the previously, just on that point, the Charitable Funds Committee has agreed to fund pilot roles where the vision is sort of over and above. That's the test for the charity is it over and above what the NHS is expected to fund. The problem with doing this is that they become really essential roles, and then actually we have to build a business case for the organisation to take it forward. And actually, when the finance of the organisation changes, well, there's different pressures or competing, pressures on funding for posts. It makes it really difficult. So people get used to having a great post in place that really enhances the experience. But it's not something the charity can sustain. The charity can't continue to fund a post like that. So I think one of the things for us to discuss at the Charitable Funds Committee is our approach to this in the future. Because whenever we introduce a temporary post of some nature, it has a positive impact, but then it leaves the trust potentially with the bill to pick up, or the reputational sort of dent if it decides not to, but for some financial reasons. So it's challenging in that regard. But
I don't think that's just something that the charity and the trust have. Lots of charities have that, because you get seed-pool funding for something and constant funding. So
I mean, it's a classic approach in terms of over hundreds of years and what's happened in the UK. And what with this post, it's a nice to have. It's providing a lot of benefits because there has been. The issue is the trust then still has to make a decision going forward. Is that something? And so that's the first one. Just the second point, I think another is highlight the fact that applications were assessed. We've got a fairly rigorous kind of matrix, and I think it might be useful just to kind of make people aware that it's not just kind of Oh, well,
Just,
that's a good idea.
Yeah, absolutely. Yeah, the committee does assess all non-spend. So there is a the way the charity is constructed, as Hayden's described, you've got restricted funds that are appeal based, so you're raising money for a particular purpose and spending for that purpose, and you've got legally restricted funds where it's very much very tightly controlled and managed. And then we've got a general pot, which we allocate into sort of sub pots for wards and departments. And people are able in those wards and departments to have a sort of smaller discretionary charitable spend, so they can find things that meet the charitable objects. But anything that's a significant spend, apart from the limits off the top of my head, comes to the charitable funds committee for approval. So we would then direct, investment in larger projects and programs of work. And the charity does that and tries to spread that sort of equally and with parity across the organisation. Obviously, some areas are always more well off because some patient cohorts tend to raise money. Cancer is one of them, stroke is another. There's more fundraising that goes on those particular areas. So we try and distribute our general funds to those areas that may not get as much direct fundraising. So acute medical wards, don't tend to attract lots of it, but they're really important, to be able to provide those sorts of benefits to patients who use them. And the charity is doing some phenomenal work around. And Vanessa and the team, it's a really small team, and Vanessa's seen quite a bit of change in her team in the last couple of months, particularly. And Vanessa works extraordinarily hard along with the other mental team to do a really fabulous job. They spend an awful lot of hours outside of work hours, fundraising and building development partnerships. And I know they get great support from Hader and from you as well, William, on that committee. So
I think it would be fair to add that Hader and William have really helped me over 4 or 5 years involved, whereas there was quite a difference of spending money at one point.
Absolutely.
I think that there's a balance always in all these things, but that has definitely evolved. I've seen that evolve very well. Yeah. Jonathan, you had your hand up.
Yeah, thank you. I guess just introduce myself personally. I'm Jonathan Knight, Future Finance Officer for the organisation. So welcome all. Just worked previously around pilots, which don't continue. Like funding in previous organisations I've worked out, I think the trick is to connect the charity funding business case process from the philanthropic business case process. So you're clear from the outset what's the criteria whereby it'll either be continued or not. At the end of the pilot, I think we can do some work on that. So happy to work with colleagues, but I think we need to be clear, either it's going to pay for itself, it's a priority quality investment. I think that should be determined ahead of the pilot, rather than after the pilot.
I was just going to mention the board one more time, because I was asked to mention it by Vanessa. The awards recently, I think numbers are in fact low. As a result, that some teams did get sold. And I know it's a very good opportunity to raise money. I know they struggle each year to make it as successful as it could be and should be. So for those in the constituency, I know there's a lot of money right now, but at the same time, it does very good work. So perhaps spread that word far and wide within our communities, which I should continue doing business.
Thank you very much, Hader. I know you've got to go.
Thanks, Heidi. Last thing I'll say, just on that MAF, it's very difficult to hear people on the other side of the table. So I'd completely echo Keith's comment about the owl. It'd be really good to get some proper tech. We do pride ourselves on good tech at Milton Keynes, but we still seem to struggle with the audio visual. But just on the MAF business case, Jonathan, we'd welcome input. I think we did try and tie it up to a business case, and to be quite honest, I'm not sure why we haven't managed to flip it over. So I'd love to continue that discussion with you. I think we've been funding it for nearly 3 years now, so it'd be great to make a call on it one way or another. But thank you all, and I hope you have a good rest of your meeting.
Thanks, Adam. I just wanted to say that, and this is Nelson Governor, I'll make this clear, this is chair of the Friends of Milton Keynes Hospital. Vanessa and I have been working quite closely together in the last couple of years, I suppose. And we do we do fun part of the children's thing and things like that.
and we do fund a number of other things. But we have been working quite closely together in regards to gardens in the hospital with Vanessa, and I think there's something about it on the hospital charity website. And I think it's very important that the two work together, because years gone by, many years ago, the Friends were the strongest charity. It is now a weak charity, to be quite honest, compared to what it used to be. But we still have a shop. We do raise a bit of money. We don't have the same complexities sometimes as the hospital charity does, like provide tables and chairs and things like that quite quickly, whereas it's got to go through a bit. So we are trying to work together so that we're actually confident. And again, I'll say, if anyone wants to, if any of the governors want to come round and do the award round, Tom did it last week, and he found it very educational. Tom says, no, I'm happy anyone round on the front.
You have to congratulate Claire on having this enthusiasm and the stamina to do that round regularly. But I found it very informative, and I enjoyed it. And I did get asked for cans of beer on a few occasions from the colleague, but which I couldn't comply with. But there we are. So thank you. Yes, I did. Thank you for that.
Thank you, Tom. I'm going to move it around slightly so that we can go to the dementia care presentation, if that's all right.
It's absolutely fine.
You've done it. Your introductions.
Yeah, you're right. So I'm Janet. I'm the dementia lead in the hospital. I started last June, so we've been working on several projects going forward. Just a brief thing about dementia. Sorry, some of you may already know, and some may know nothing. Who knows? But it's an umbrella term. There's definitely lots of different types of dementia. Alzheimer's being our most common one at 60% of our dementias. Now, it is not a part of natural aging. It is actually something that is going on with the brain due to blood supply or proteins being built up, but some reason why nutrients can't get to that function, can't get to that part of the brain, and then it's not happening. So it's not a part of natural aging. Just the common myths. And the common symptoms, obviously, low people go straight towards memory loss, confusion, and that's the usual signs. But there is other signs like visual perception. So in hospital, we quite clearly noticed about flooring and stuff, because the differences in flooring can really hinder someone thinking there's a stair, or actually they're going to drop into something because of the different colouring. So it's really important to look at. Also, even another slide, sorry, I'm talking quickly. Or it could be something like communication difficulties, losing certain words. So it's really understanding our patients and understanding what they're trying to get across. We had a patient that was like talking about their catheter and they were calling it V1. So it was learning actually what are they trying to get across and what are they trying to say to us, and having that patience with people. I think the bigger one that's normally quite a hard one to manage is mood changes and personality changes. And that's what we see quite often come into hospital, because they've not been able to pinpoint it in the community of what's going on. They come in because it becomes a social problem. And that's normally the ones that we see that are quite a bit more challenging to manage and look at and pinpoint what's actually going on. From those lovely symptoms, we get behaviours, which obviously in a hospital setting is really challenging. They don't know us, we're in a strange environment, and it could be noisy and a lot of things going on at once. And that sensory overload can really impact a patient. So it's, again, learning about our patients. So we use stuff like What Matters to Me booklet, Alzheimer's Society, This Is Me. So it's a booklet that just learns about the patient. Relatives can write it, staff can write it, whatever we learn about that patient, we write in there so we can continue their care and make it as seamless as possible. If they like talking about cats, we can learn they're talking about cats, but we can learn those kind of things about patients just to make it a little bit easier while they're in hospital. So these are just some of the statistics that come through. So it is the largest cause of death now in England and Wales. So, and it is just going to continue growing. So unfortunately, dementia is not going anywhere, and we've got to learn how to adapt our care to it. It's going to affect each walk of life, so we need to adapt our thinking. We have probably about an average of 65 patients as inpatients in the hospital per day. That doesn't include outpatients, it doesn't include endoscopy or day surgery or anything, that's just the main key wards. So they'll be higher than that just in the hospital. We need to look at the advanced care plans. So 63.9% of the patients die in their place of usual residency, but that leaves a large chunk that isn't. And we need to look at that and see where we can improve on our advanced care planning of our GPs as well as ourselves. We already know where this condition leads to. Actually, what are people's wishes? What do they want for their last months, days, years? And what are their key things that are important to them? So it's really getting that message across. I also put just a statistic in there about Finland and Mauritius. That Finland had a higher diagnosis rate compared to Mauritius. And that's mainly because the life expectancy is better, the medical care is better, but also there's a cultural aspect. So even within Milton Keynes, we need to think about the different cultures that are in there that will accept a dementia diagnosis, and some may hide away from that and actually keep it in-house within their own families, because we need to touch upon those cultures to say, actually, there is a lot of support out there for you. And that's why I've added that just a statistic to understand that we do need to touch upon that. So for me, main role obviously is supporting patients and relatives from diagnosis to end of life care, everything in between eating and drinking issues to challenging behaviours, agitation. I can support that on board so people get the best care they can. Obviously promoting dementia awareness, places like this. Education, I'm doing inductions, I'm doing bite-sized training. It's just to make sure all staff have knowledge about dementia, because it should be everyone's business now because of how quick it's growing. And I'm also developing lots of links with the services outside. So we've got mental health liaison services with the psychiatric side, and they're great at having us with medication reviews and seeing how we can best support patients. Frailty team, it easily links in with frailty. Unfortunately, the age range we're dealing with, a lot of other comorbidities come with that. So we need to look at these patients holistically. Charities, so we've got really excellent charities out there. We've got Alzheimer's Society, Age UK, MK Carers. They're all really keen to make links with the hospital to ensure that we get services for patients and support. And then the community, we've got Admiral nurses and GPs that are also keen to make sure we've got those links. So actually, when a patient gets admitted, what's been going on in the community, and can we continue that to make it as quickly as possible to back out really, because they don't want to be in the hospital. It's not the environment for them. And that's just a tool that we use to challenging behaviours and do education on, because there's a communication tool, as we were talking about communication, of actually validating people's emotions and what they're trying to get across rather than going straight to distraction. And pinch me, don't pinch someone, but it's just acronyms of understanding could there be a reason behind those behaviours. And then another part of my job role is doing certain projects on how to improve services for patients. Dom's campaign is quite an important one that we launched last year. So this was based on the fact that went into hospital pre-COVID, they got norovirus on the ward, so no visitors were allowed in. And he significantly deteriorated mobility-wise, even drinking, cognitively. Family felt if they were allowed in, they could have supported with that. And there's great evidence to show that family are really key to a lot of patients' cognitive function. They may eat and drink better with them. They may have a wash with them. That's what they're used to. They're used to that routine. So as a hospital, we've adopted that and allowed people to come out and visit hours. Obviously not the whole family, not cousins, brothers, everyone around the bedside. One at a time to like help out outside of visiting times. But if that's their usual, I would see it as a win-win situation for everyone. Patient, the relative, and us, because it's actually the patient big pharma. So the math role they've just spoke about briefly, there is a business case going through at the moment. That is with seniors now. So hopefully that will be looked at very soon. A decision will be made on that role. But we do also have volunteers that are meaningful activity volunteers that will go out and support patients. The cognitive function and stimulation is really important for patients with dementia. So it has, if they're stimulated, it has improved to show their outcomes will be quicker. So they'll have a less stay here, and obviously their function will remain. So we're not losing that function while they're in hospital. So it's a really important section. But we do have volunteers as well. So we'll see what comes of that. I won't go delve into that too much. And then ongoing projects. So Department of Health have recommended Tier 2 training for anyone that has regular contact with patients with dementia. This was giving staff the right tools and the knowledge to support patients out there. So that's what my next big challenge is, to get everyone trained on Tier 2 training. Continuing our connections with the charities. They're so important to us right now. They're really supportive of the hospital, and they'll be support leaflets. So that's another thing that we're going to be looking at. So for discharge, what can they expect? Eating and drinking is a really big one that I've been working on. So we've been doing finger food platters. Actually, do you refer in because of cognitive problems rather than actually the dietitian, even though it's very important, but it may not be a diet problem, it could be a cognitive problem. So it's looking at actually the different aspects of why that person's eating. So getting those leaflets out there. And then looking at the environment, we do a place audit once a year, so lots of people join and look at the environment, but obviously that we need to look at that as a dementia perspective. So everything we do, we need to look at it with a dementia twang, because we need to adjust our practice. So even with your important lists, sepsis, how do we recognise sepsis with a cognitively impaired patient? How are we going to adjust our practice to understand that? This is all going to change, and we need to adjust with us with everything we do. We need to have a little twang. We're thinking, actually, if that patient doesn't have cognition, how are we dealing with that? So the next bit is just strategies that are out there. There's plenty of strategies, and you are welcome to read them if you so wish. It's up to you. But also, we are doing a dementia awareness week in May on the 16th. We are doing an event in the Marquee near the restaurant, which will have 16 stalls now, explaining what they do to support dementia within the community. So it's open to public and staff to learn what support is out there. So anyone that you feel may be interested, please let them know. It's a really good opportunity for them to get that information and get lots of different information in one time. They don't have to get listening. Lots of work to be done. Lots happening. Oh, please do. Yeah.
So you had the Alzheimer's Society at the front desk?
We do once a month. So we came to agreement that once a month to highlight their special stuff they do.
Just for governors and community, so I chatted to Michelle Leahy.
Yeah.
So she's coming with a table set up into our community, because we get lots of people through food events for a day to do, just so they can come in and do that. So if anybody else has got set up like that, we get other people just to come in time to time, just so it puts the important sort of community.
Oh yes, the access.
Don't come and ask questions, whatever.
Yeah, no, brilliant idea. And I think anywhere that we can promote what helps out there, what supports out there, is a great idea. Because, sorry.
I just think it's worth mentioning the BLMK.
The BLMK, that meeting we made earlier.
Because there's across the integrated care board, there is a strategy being put together, and we know that Milton Keynes is drawing up the strategy, and the idea and rationale is to make that an overarching strategy, so that what's good in Luton's strategy is highlighted, what's good in ours is, and so that there's a cross-border strategy. And I think in reality, that should help.
I think it should. I mean, even in that meeting, we discussed about Herbert's protocol, which is with the police, where you can preempt if someone went missing, you give them all the details about that person beforehand. So they have it on record. They know that there's a vulnerable patient that lives in a certain address, so if they ever get called out to that address. And Bedford and Luton are doing that really well at the moment.
Yes.
So we need to nick their ideas and bring them here. Yeah, sure. But there could be loads of work done with it, I think, an ongoing project.
Well, and patient has different issues. And some just lose the ability to swallow, for example. Others just lose the filter. So they appear incredibly rude because they're straightforward.
Thank you very, very much. That's,
Thank you.
Oh, I'm so sorry. I didn't see a hand there.
I was only going to ask, do we have many young patients? Because when you read about all the data, there's a lot of
We're starting to see
coming down in age when people are being diagnosed with it.
Definitely there is an increase of young onset dementia, which some is classified as under 65. But we don't see as many in hospital, and that's because usually physically they're quite well, usually. So we normally see them in front of us.
Brilliant.
Thank you very much.
Coming back to this meeting. I'm having a good day on names all around. I am. Meeting to meeting. So I'm going to take us back, I think, to the questionnaire, Kate. I'm going to give you a very limited amount of minutes on it.
Couple of minutes, yeah. So I think I mean I think the paper is very self-explanatory. This is an exercise that it is good governance to do. So an annual review of effectiveness, and we do the same with board committees, just to get an idea of where there is development requirements and where people are quite content with how the council governance in this instance is doing. So there are 3 recommendations that are proposed, which is that we adopt this framework and that we conduct this exercise in the next between the 1st and 15th of May. So can I just help with that?
Because I can't do it.
And it wouldn't work. So and it will be, although it will come back from your email address, it will be an anonymised result that will be created and presented. It will help us for the secretariat.
Any questions? So it takes us to the Finance and Investment Committee summary, which is obviously from myself. It's the lovely complicated world of the NHS finances. That's why Johnson's on board, who I should have introduced at the start, so I failed miserably. So he's there to back up with the Jonathan's also is going to just mention in 3 minutes about the forward plan, because obviously really finance is always moving forward and it's more about where we're trying to. So the document reads for itself. I think the important thing to say is Finance Committee meets monthly, so it's the one committee that does meet every single month rather than quarterly. I think in terms of seeking assurance, in terms of timeliness of reporting and accuracy of reporting, certainly the committee looks to make sure that that's what's happening. Actually, during this year, we've changed the timing of the reporting, so that came from the reference from our audit committee and requested externally as well in terms of timing we are reporting to ourselves. I think we have a strong team, and obviously during this year we changed to have a new finance director. And I think that we knew last year was a challenging year, but was not going to be anywhere near as challenging as the year that was going to lead us into for 24-25. And I think that we were very aware of that. And what key thing throughout the year, apart from funding that might come into us from other bodies, from NHS, the wider NHS, was really about that we were not building sustainable cost efficiency. We had a lot of one-off activities and a lot of one-off savings that were enabling or one-off income streams that were enabling us to carry forward. And I think really from July, August of last year, we knew we were talking about the fact that really post-pandemic, we hadn't got back into that growth as an organisation of creating that efficiency drive way of operating. Certainly when Jonathan's come on board, it's something he's been completely focused on from the off of his first meeting with me of, we can't go on like that because we simply are not going to be able to deliver what we need to deliver as bottom line. But that said, I think, the team have done a very good job this year, particularly as you can see from the number of business cases that go through, the activity that happens. And also we have the hospital programme beginning to get underway, which we, again, is something we're talking about how we bring good governance to that, good reporting to that. And as we're developing that inside the committee, I think we'll also want to be thinking about how we communicate that with governance so that when you're then talking to the wider population, you'll be able to talk about what's happening to your hospital in terms of the development. I think the good news is good news, but I think the good news at the moment is we do keep getting funding for the next iterations of development or the planning works and there's digging going beside, as you see, for high voltage lines. I think it's good to be in that group because not all of the hospitals who were on the original plan have been in that place. But I think the real focus for us has to be how we deliver safe, effective care in as financially efficient way as possible with all the challenges that we know see around us. So I'm very happy to take any questions. But also, I think Jonathan wants to give a really impact on the new plan that we've set down in terms of the year ahead.
Yeah, I was just going to do a very quick one, summarise where we got to the end of last year, the net numbers, and go on to that. So, thank you and welcome again all. So, the plan for last year was effectively to break even. And pleased to report that subject to audit, we are likely to deliver that position. So, despite all the challenges which I just referenced, we are going to land it effectively in terms of where we expect it to, which is really important for external credibility in terms of the organisation financially. And that's been delivered, as Heidi says, largely by the additional volumes of activity to all intents trading our way out of financial challenges, so which is fine, but not necessarily a sustainable long-term position. In terms of the year ahead, we're currently amidst the planning round at the moment. So, this is still provisional in terms of direction of travel, but we are going to be submitting a deficit plan for the forthcoming year. If you read anything in the media, you'll see this is likely to be the most challenging financial year in the NHS for a long, long time. We are very far from being the worst organisation with respect to having a planned deficit, but nonetheless, that is a challenging position to be in. Just Heidi has already said, one of our priorities has got to be really motoring in terms of delivery of efficiency, productivity, making sure that we can demonstrate that we're doing everything we can to maximise the patient pound in this population. So we're going to have an efficiency target for the next year, which is going to be circa 5% of our turnover. So very significant, very challenging. What I am pleased to say is actually in the 6 weeks I've been here, we're making some really good progress in terms of identifying how we'll do that. Joe alluded to it earlier. We have some very, very significant challenges, and almost as much as work we do, the waiting list continues to build. So one of our challenges is how we continue to deliver the work required to bring down waiting times, but do it in an increasingly financially efficient way. So to be brutally honest, that's our biggest challenge for next year, is how can we deliver on that? Because if we can do that, we will be able to move increasingly towards financial balance. So going to be challenging. Position's not launched yet, but hopefully gives you a flavour of the direction of travel for the organisation. What we do need to do is, as we go into future years, determine how we can get back to balance and beyond. So obviously that's a challenge for this year, but then future years as well. So always taking questions.
Mine was really about training. I did have a chat with Alison when I first joined, because I've come from a non-NHS background, and NHS finance is really difficult. I mean, there are just terms you don't understand, like elective recovery and are we paid per patient, per bed? I mean, these things. And I did suggest, or Alice and I sort of thought that it would be a really good idea if we could get a presentation to the governors just on the basics of NHS finance. So we've got some understanding when finance comes to us about what these key figures mean. And that would be, I wonder whether that would be possible.
Really happy to do that, whether it's a main government meeting or a development day, absolutely happy to do.
I think we've got that on the list, and I'm trying to think where we've got it on the list, but we have said absolutely, but that's something we don't need to do.
That would be so really helpful, because I think there are plenty of new governors. I think some more, maybe it's only just me, but I suspect not.
It's ridiculously complicated. So.
But it's not like any other commercial organisation either.
No.
I know you always get funding, and that's really great. I'm doing a smaller capital programme, and I got the funding last year, and it's not going to be built until this year. And I've got 100k to find, and I'm just wondering if funding that you get takes into account the delay. Because, you know. So delays can happen both ways, but we think money's coming to us, or we think we're going to do an activity and we haven't. But I think, but with terms of building costs, you know, they jump.
Yeah, probably 10-15% over the last 12-24 months, absolutely. So I think that's a critical part about this is building sufficient contingency here, so you can account for inflation, and then you say timeliness of approvals is really pivotal. Not least with the new hospital programme bids, that's going to be our big challenge to keep that containable with the envelope we are bidding for.
I think it's why it's important at the end of the new hospital programme, I won't say it, the new hospital programme. Yeah. There is a big contingency in there. And all progress we can keep making. That's a reason well, the construction costs are just need to be set up.
Question really relates to again what Joe was saying earlier about with our new facilities, we're attracting like outside patients. How do you ensure that we get payments for those patients or for that activity, and how does the activity match up to the ongoing running of the new capital infrastructure, I suppose?
So
I know it's a really complicated answer, but
so in very simple terms, it's a massive simplification. If it's a planned activity, so outpatient first attendances, procedures, day case facility in patients, then to all intents, we get paid for that as the work materialises regardless of patient comes from. There's some caveats around that.
Yeah.
In terms of unplanned care, it's a lot more challenging. So effectively, we are in a block situation. So we are reliant on that block funding keeping up with demand, and that is an ever increasing challenge.
And with our population.
That will continue to be a problem.
Yes.
Yeah, just on, there's been a number of things tonight on presentations like finance or information on the top 6 priorities. Governors all at very different levels of understanding. And I'm just, as I was considering earlier around this, I think if we've got presentations that are at governor level, by that I mean enough information, but not all the detail, because we're not all experts and we're here for 3 years, unless you extend your term. Enough to ask the right questions and make decisions, I think, as a principle. And I'd certainly wish to be an expert like everybody else. I am a lay governor, you know, blah, blah, blah. So I hope that, just as a general, we do trust you. We want to ask questions.
Very good. Now, I think it's some choices to make. So we have less than 10 minutes. So the last part of the agenda, we've got the programme for membership engagement board. Which I think is a burden.
I've covered some of my things within the conversations. I'm happy to skip, and I can send a briefing.
Sure.
Yeah, absolutely.
So should we try and do the other 3 parts? Would that be all right? Yeah. Okay, so the capital programme, John, you.
Yeah, I think I wasn't going to, but I think the paper largely stands for itself as a progress update.
Yeah.
It's our key capital schemes. There's not a huge amount to report. A couple of areas where we've had some delays, but otherwise things are progressing as well there.
Okay, thank you very much. Kate, I believe
yeah, I mean, I think it's again sort of self-explanatory. It's a summary of current elections that are underway, shift in membership numbers, which are positive, and some of the activity that people have been doing. Thank you very much for your work. constituency areas. So it's just here to know.
Small correction on activities. If anyone's looking for the information, it's the April edition of the Army phone box that it went into. So you won't find it in March.
Inclusion in the Leadership Council report, I haven't got that.
No, I haven't either. We'll bring it back next time. I think the ILC has met. I wasn't able to attend the last meeting.
It meets every other month.
It does, yeah. So yeah, I'll pick it up as an action for next time around bringing that back, and maybe it transferring in terms of people presenting from the chair, so maybe a member of the Inclusion Leadership Council rather than the chair.
Yes, Alison and I have talked about
Yeah.
it in terms of how you feel around.
Yeah.
The next one is so perhaps we can do that as part of that.
Maybe
sort of movement. So
roam around and work with chairs. Yeah, start the questions.
Actually, I think that does give you a few minutes. There was something you wanted to say.
Definitely done in a while. It's that time of the year. I apologise for not giving a more detailed report. I was on holiday then the next month's Easter period. So I thought I'd just quickly brief you on our Health Watch Milton's business plan priorities for the year, because we've got to put together, we've got those together for the year, some plans that we have been discussing with Louis as well. So no surprises, we'll be focusing again on primary care this year. It continues to be the key issue that residents raise with us, largely still around waiting, challenges getting appointment times, how that can be connected to waiting lists, as well as communication. We are currently in a process of rerunning our GP survey with some information about how patients are, whether they feel they're using primary care or other parts such as pharmacy, GP services, etc., due to being on long waiting lists. So we thought we could hope to explore that a little and infeed some of that information into these developing fuller neighbourhood working, fuller neighbourhood staff, primary care, place teams and young teams developing. We are undertaking 3 projects for the Integrated Care Board under the Delhi Review recommendations, one of which will touch on hospital services, which is a review of all the translation and interpretation services across Bedfordshire, Luton, Milton Keynes in collaboration with the other local health board. It's a really big project. We're still working out just how in depth it needs to be. But ultimately, it as well as finding out the provider, and I know we've been speaking to Kate recently about some issues with provider services, but at the Trust Board last month, there was a really good presentation about Sign Live, and a lot of candour about the capacity issues in terms of staff training and support to them to use the kind of equipment as well. So it'd be kind of exploring those things with staff, exploring patient angles, finding out what the gaps are, and really going back to the Integrated Care Board about what, you know, places like Trust and primary care need from future services. So hopefully that will be a really big influence in piece of work in the future. We'll be also running some health events, and we'll be working with some local patient groups in GP services to develop a toolkit to support growing diversity amongst their patient representative groups, again, about strengthening that neighbourhood working. And hopefully we'd like to see things like those better connections between hospital governors and on those PPGs. What else is relevant? I will skip the rest. I will send a briefing round so you've got all the priorities. But what I've been connecting with Louis on is that we've set out a programme of 10 monthly sessions that will be running each month, but the engagement and listening sessions for residents. But there are a number, including patient participation, that I think governors might be interested in, and we're liaising with Louis around who might want to attend that event. So the idea is it's not just about listening about experience, also helping people to understand how to get involved and what support and networks are out there as well. So there'll be a number of both health themes and participation research sessions over the next 12 months. So I'll circulate that as well, work with key people to find out whether clinicians or members of the council are appropriate to come along, and hopefully it'll all go to plan. Lots on.
Okay, is there? I was just going to say, with those sessions, so you're doing those across the piece, but you're going to use community buildings to use, so they're in place.
Yes, we want to make sure that they've got a really good spread across Milton Keynes. So they'll be quite well, you know, they're going to be kind of month-long campaigns with a session at the end. So it's about helping introduce people to the information about a particular topic, making sure that we're getting the right professionals or members of the public who represent patients and residents in those sessions as well. So there'll be a bit of fine-tuning around planning over the coming months. But the aim is that we'll have them in hopefully the right, either targeted at the particular communities that we want to speak to, or at least certainly more accessible venues and things across Milton Keynes, so everyone gets an opportunity.
Answer around the room for any A and B. Pretty much do everything live.
And then if that's right with everyone, I'll just look round. How's it easy for you, Matt?
Today's meeting, I feel like there's a different atmosphere to this meeting today. Is something a bit more, it's positive as it normally is, but there's something extra. Plus, we seem to be all on the same page and now really challenging and asking the right things. And I think it feels like we're going in the right direction.
Yeah, it's like informal session.
Yeah. I'm not sure if anybody else has felt the same. It just seems like a different spirited meeting this time.
Yeah, much the same, no experience too. So.
It's my first council of this meeting, and well, contrary to the impression I had, I think this went pretty well.
Probably give you marks on. So.
Yeah.
I think it's great to see so many people here in person. I think yourselves about how difficult it be at that end to hear.
Yes.
So, you know, we do something with that now.
I've got that actually on my list.
You know, it's completely influenced what I was saying about the what we're getting is a good mix of engagement and challenge. Because that's exactly what we need. We need us to be asking robust questions and sort of dealing with, you know, getting the grips with often very complex information.
Yeah, rather than just floating through the papers, basically.
Yeah, good for me. I love hearing what you guys need to know. It's all joining all the thumbs up to me. And that's how I think, you know, I better will take way to it to try and be here in person every now and again as well.
Maxine, how was it for you?
I agree with Babs. I think it has felt a lot more animated today. I mean, I felt because I've had that refresher training recently, I think it was just kind of connected me a little bit more to.
I thought it was good. I'm just sorry I was late.
Different perspective. Nice to see.
First meeting, yeah, so back slide.
Yes, my first formal meeting as well, but yeah.
And I'm sorry, I should have welcomed you. That's my fault for not kind of following because normally here and not here, but I will get there on that.
Yeah, I don't know if this is the opportunity to just do suggest something for the future. I mean, we've had a suggestion, I think, about the finance. I think that a theme, and it's come up in the complaints and the discussion about the priority. A couple of emails that I think everybody has received about complaints that are in progress. It seems to me a strong theme is the interface between hospital and community and discharge planning. And I think it would be helpful for us to know what system should be, because people are continually coming and saying, why doesn't my GP know this? You know, why did I not get a district nurse? Why were we discharged home and with no follow-up? It just is a core thing. We all know the NHS is not a whole system, but if we could do that really well in Milton Keynes, I think it would be massive.
Christine, don't believe everything that primary care is.
Well, I come very much from a community. I've managed all the health visitors and school nurses for 10 years in Milton Keynes, so I have a lot of experience with primary care. I also manage district nurses in Milton Keynes, so you know I'm coming from both sides. I know it's difficult, but unfortunately I've been retired 10 years and it doesn't seem to have got better.
A very good integrated discharge team. I want to know about each presentation that comes back.
Yes, I'd love to know where it's, you know, it is falling down, because that's where the complaints are. A lot of complaints are about that interface.
There's lots of capacity issues around social care and older care.
Absolutely.
Sorry, I was just going to add something. As we're working with the MK deal at the moment, we're hoping to do a patient evaluation of the integrated discharge pathways as they develop. If I can get through a couple more hoops in terms of GDPR and things, and hopefully what we'll do is the discharge team will be able to send us a selection of patient details so that we can bring them, and we'll go through a set of questions and evaluate how those pathways 1 and 2 discharge pathways are working. And I think not only will that help that team kind of respond in real time to how those things work with the patient, but also we hope that we'll get a bit of a richer sense about what's going on after discharge. So once that system is in place, how is that working in terms of that interface with primary care? So all going well, it was supposed to launch in April, but those hoops are really difficult. So I think it should launch around June at the moment. So I will bring some updates.
Yes, I agree with that, Shanti. I would highly recommend our labs and get some of their kit. Yes, because it is awful. I was up there last meeting. It just isn't. Yes, whatever you've got is fine.
Absolutely. I was learned something from this meeting around what we can do in improvement. So thank you.
Very good, thank you. Well done, your first speaker.
And then online, Gary and Lily, Ken, is there anything you'd like to say about how the meeting was for you, or is it mainly can't hear you very well? Caroline.
Yeah, that was a good session.
Thanks, Gary. Someone else speaking, sorry. Gary, yes.
I thought the questions were much more to the point in this session, so I thought it was overall a much better session. I just echo some of the comments about it's a little bit difficult to hear everything.
Yeah. You're definitely going to take that one away. John will be hearing. Thank you very much. So I'm going to say thank you very much to everyone. Oh, Tom, you're going to speak.
No, I was just going to repeat I was just going to say what Gary said. I heard the chap from Dubai far better than I could hear at the meeting. And I would say apologies for not being there today, but I visited my sister down in Hythe. But it's just as difficult to hear here as it is in Buckingham, believe me.
Yes. You don't just need to shout louder, that's not going to work. Thank you very much, everyone. I'm going to say thank you very much to everyone online. Thank you to everyone who's been listening. Thank you. Thank you. Thank you.